we all know, I am a shoulder and elbow surgeon for 18 years now who does a lot of shoulder and elbow trauma. So I'm going to show one of the most difficult, interesting, and lovely cases of my life. And let's start with this. So this was one of the most interesting cases I have ever had. So this case was about a 38-year-old lady who lived in the Amazon. I use it to operate in the Amazon strongly, as my Indian friends know, from 2011 to 2019. And this is an Amazonic lady who had a proximal humerus fracture in the right shoulder in January 2018. She lives not in a big city. She lives in a faraway city, but is a very, very oriented lady. A phyllos plate was done by a local trauma surgeon, and the surgeon said to the family that the surgery was fine and everything would evolve nicely. Nevertheless, the patient evolved with strong pain since the very beginning of the post-operative scenario. The shoulder developed very fastly stiffness post-operatively, and such problems were never getting better after surgery, month after month. As per the patient and as per the family, the surgeon was always saying that everything was fine. And this lady, she was 115 kilometers away from the capital of the state on the southwest of the Amazon. So finally, she went for a second opinion with the local orthopedic surgeon, and the local shoulder surgeon saw the case. He could understand what was going on, and he gave me a call here 2,000 kilometers away from him, saying that Houston, we have a big problem ahead. So that was the AP X-ray of the patient about 11 months post-operatively. That was November 2018, 11 months post-op. I'm going to comment the AP X-rays, the AP view in a minute, and that was, and here we can see, for us who have a good experience in the area, that was a posterior dislocation, anterior or posterior, but I'm going to show you the CT in a minute, and that was indeed a posterior dislocation. I'm coming to the X-ray in a minute. That was a well-positioned left view, but it's not so conclusive as we all know. If we take a better look on the AP view of the shoulder, this is in green, the glenoid, and this is here, the proximal humerus. So it's obvious that that was a locked anterior or posterior dislocation, but you are going to see the CT in a minute, and CT was obviously mandatory. I would like to highlight that this lady lived 150 kilometers inside the rural Amazonic area, in a way that we don't have all of the nice exams that we would have. So she did a CT in old fashion, in which we only had the axial cuts, okay? But this is the CT in the axial view, in which we are seeing this 11 months or 10 months post-op. So what are we seeing here in this CT? The humeral head was posteriorly dislocated, and some screws of the phyllos plate, they were destroying the glenoid. We all have experience. I have a lot of experience in this field, so we can easily say that those screws, they were scratching, I would say, the glenoid for a lot of time, because it takes a lot of time to have all of this indentation of the screw, causing all of this bony defect on the articular cartilage of the glenoid. And gentlemen, she's only 38 years old. This is another CT view, and we can see here no previous signs of drilling in the humeral head, okay? And if we see this other cut, this other image, a little bit higher, again, no signs of previous perforation on the humeral head. So we discussed this case a lot of time. It took us a lot of time to figure out what we would do. But the thing is, to the best of our understanding, I feel very tranquil to say that much probably that was, in the beginning, a 3-part posterior fracture dislocation, or maybe a 2-part, but I'm pretty sure a 3-part posterior fracture dislocation. And to the best of my understanding, the colleague would not have noted that the humeral head was posterior dislocated, and hence he fixed the humeral head on the glenoid. And this is why she was having a lot of pain since the beginning. And in my opinion, considering that there were no signs of perforation in the humeral head, I can assume that the real diagnosis was not fully understood by the local orthopedic surgeon. And now I have a patient, basically 11, 10 months after surgery, 38 years old, with this scenario, a clear destruction of the glenoid, which was being scratched by some screws of the phyllos plate, a dislocated humeral head, which was unquestionably going to AVN, much probably, as a shoulder and elbow surgeon, I can say, a very, very suffered rotator cuff. She was in agony. To be very honest with you, her life was going bad. The marriage was going bad. She was fighting for her from her job. She was in agony, and that was the bomb we had to fix. So before I show you, my friends, what we did, Dr. Vincenzo, I would like to hear you with this very, very easy case, my good friend.
Thanks, Sergio. I think you did the summary very nicely. The fracture was never reduced nor fixed adequately.
Yes.
I think maybe this was a 2-part, because I don't see any signs of bone healing, both in the lesser and in the greater tuberosity. So I think this was a 2-part posterior dislocated humeral head. That was never reduced nor fixed, as I mentioned, you mentioned also. There is an injury on the articular surface of the glenoid, but again, the patient is very young.
Very young.
There are no signs of a vascular necrosis of the humeral head. And in my opinion, if you allow me to move a little bit further, I think with this age, with a humeral head that demonstrates no signs of vascular necrosis, I think we have to try to do an osteotomy and redo, or at least try to do a very nice osteosynthesis. I think this is the only way to try to salvage this humerus head, but the patient has to be completely aware that with this procedure, first, this humerus head can now have an avascular necrosis. Even though the humerus head has no signs of avascular necrosis and there is a secondary bone healing after this secondary procedure, she can experience pain because she has a very large damage of the glenoid surface, and we don't know for sure the profile of the rotator cuff.
Yes.
And after all, she can have third surgery because she can had the fracture healed with no signs of avascular necrosis, but she can experience pain and she will need a third surgery. But I will try to do an osteotomy and a fracture reduction and another fixation.
even with the quality of the glenoid, Dr. Vincenzo?
Yes, because of the age of the patient. I think we have to try to salvage this humeral head, but we have to put the patient completely aware that she can have a bad outcome. Yeah, she can, despite of an adequate reduction, if the fracture heals adequately, if the humeral head still shows signs of no signs of avascular necrosis, she can keep on experiencing a dysfunctional pain, and because of that, she can need a third procedure, maybe in this third procedure to do a replacement. But I will try in this secondary procedure to salvage the humeral head.
Okay, and if you operated this lady in an ideal scenario, would you have in the operation theater a prosthesis ready to be used or not? This is a lovely question.
In the secondary procedure, or if I was treating the patient since the beginning?
See, if she came to you and you said, okay, I'm gonna try to do a reconstruction, would you have, by safety, some kind of prosthesis in DOT to use as a plan B?
Yes, for sure. I think it's necessary to have a prosthesis in the operating theater, because you can be the best surgeon, but anyway, you cannot be successful in reducing and fixing this fracture. So I think it's necessary to alert the patient that maybe she can go for an open reduction and internal fixation, and at the end she can have a replacement.
Lovely. I would like to listen, Dr. Gustavo, Robinho, Dr. Luis Henrique. Do you want to say something about this case? I think that it's a very challenging scenario. I would like to listen to you boys before I show what I did. Robinho?
Sergio, it's a challenging case. It's a malunion in a patient with 38 years old, but I always try to do a reconstructive procedure. I think it's helpful in this case to use a 3D printing for preoperative planning to help the procedure, but I always try to do a reconstruction.
I fully agree, but this lady is living 115 kilometers away from the only big city of the state, and I use it to operate there for 8 years.
So I try to do an osteotomy, an intra-articular osteotomy, and fixation with a plate, screws in the right positioning.
Okay, and do you consider that intraoperatively that would be impossible?
Probably. It can happen. It can happen. But I think we have to try to do a reconstructive procedure.
Okay.
It's possible, but you have to have two possibilities: the replacement and the osteotomy. I try to do the osteotomy first.
Okay, and if you had a replacement in DOT, what kind of replacement would you think about? As a shoulder surgeon, I tell you, a hemi, a TSA, a total shoulder arthroplasty, or a reverse. But we have to take into consideration that the glenoid much possibly would be destroyed. And we have to think about the status of the rotator cuff. Having said that, what kind of replacement would you have in DOT, Dr. Robinson?
Probably a reverse shoulder arthroplasty. Actually, I don't do this procedure, but I have my friends who do it so much better than me. I have my colleagues of the shoulder team, and probably the choice for this patient would be the reverse shoulder.
Good, lovely. Vincenzo, the other two panelists, they can speak if they feel comfortable too or not. But do you want to say anything else before I show you what I did and my rationale?
Sergio, if you don't mind, it's important for a few comments. I think the patient is about 130 kilometers from the capital, right?
Yes.
But the patient got a very nice plate. It's not usually to have this kind of plate, and very cities around the big capitals. So there's a big problem because they got a colleague done a surgery with a very nice plate, but didn't get to the reduction.
Yes.
So for this kind of place, this kind of patient, it's very important to reinforce that you have to be sure that there's correct reduction of the dislocation for the head is inside the glenoid, and it's about to get reduction for the fracture outside. So I think we'll try, like Vincenzo in the Robson, as commented, we try to reduce and fix again. We try it's very important for about the age of the patient. And even with the glenoid is some problems, but we try to refix the fracture.
Okay, good. Dr. Vincenzo, I am controlling the time. Do you want me to show what I did?
For sure, but if you allow me, just one comment more.
Sure.
I agree with what Luis just mentioned, that although we are talking about a patient that lives 100 or 200 kilometers far away from the capital of the state of Amazonas, she had a very nice and fancy plate to treat her fracture, or at least to mistreat her fracture, but she had it. And again, we are discussing about and again we are discussing about fixing and or redoing the fixation with an osteotomy, or to replace it. And if we are talking about replacement, we are discussing about a reverse total shoulder arthroplasty. So although we are 20 kilometers far away from the capital, we still have some resources. We still, I can understand that we still have some resources. So if we have some resources.
Yes. No, I just want to tell you that she has insurance. No, she had insurance. She had insurance, and she would have access to a reverse with the insurance, but definitely that would not be people with such capacities to do that in the small city. So this is why she came to the capital.
No, I understood that. But what I mean is that if she has some resources and very nice facilities to have to get some exams, some preoperative exams, I think if we are thinking about to do a reversal, and we are thinking about maybe that there is an option to, instead of doing the reverse, we can do a total shoulder, a conventional one.
But
we have to we have to stratify the condition of the rotator cuff. So again, if she has very nice resources and nice facilities, she is a candidate as one of the preoperative exams to get an MRI. Because with the MRI, despite the implant and the artifacts, we can study very nicely the function and the fat infiltration of the rotator cuff, and we can classify according to Goutallier. And also we can measure the volume of the deltoid muscle, because so far in the literature, this has been shown a good factor in terms of prognosis, even though we are thinking about to do a reverse. So before the surgery, the definitive surgery, I would go for an MRI study, mainly for these two aspects, to study the viability and the quality of the rotator cuff, and also to measure the volume of the deltoid muscle. If we have Goutallier less than 2, and we have nice deltoid, I would say that maybe she can have a total
A TSA.
conventional
Yes.
proximal humerus replacement. If
Okay.
she has a Goutallier greater than 2 and a very nice volume of the deltoid muscle, I would go for a reverse.
Yes. So my comments are, we didn't do an MRI because we would be absolutely sure of the artifacts that we would have because of the plate. And we asked for an ultrasound that was not very conclusive. But as a shoulder and elbow surgeon, well, what was my rationale? The thing is, the status of the cuff would be quite bad, and I was absolutely sure. I didn't do any pictures intraoperatively because I went to a city in which I had never been, that was not my crew, and it was a very, very tense surgery, and this procedure took 5 hours in my hands. So we knew that the status of the humeral head would be quite bad, and I was absolutely sure that was the worst humeral head I have ever seen in 17 years doing this. The glenohumeral status of the cartilage was very, very bad, and we were ready. We had completely given up the idea of trying to do a reconstruction because we knew that it would be in a quite bad status. And I was ready for a TSA or a reverse. That was one of the most difficult surgeries in my life. I have a lot of experience with complex shoulder and elbow trauma as a shoulder and elbow surgeon, and it took me 5 hours to do that. So that was the incision that I have done. This is 1 week post-op. That is my incision, a classic extended delta pec. But take a look at the previous incision. That is a non-existing incision. So it just gives me fuel to conclude that the previous doctor didn't know exactly what he was doing. So the status of the rotator cuff was extremely bad. So intraoperatively, we decided to do a reverse. I did it. So these are the perforations of the screws on the shaft. This is 1 week post-op, the left view, and this is the axillary view. For pedagogical purposes, here I am showing you the clavicle. Here I am showing you the coracoid in green, and here I am showing you the acromion. And I knew that it would be challenging to do a reverse in a 38-year-old lady who was suffering incredibly. So this is 2 months post-op, absolutely lovely external rotation. The subscap was completely gone, but many papers are saying that the pec major can compensate internal rotation. I have other cases in my office with reverses in all the patients, of course, with similar scenarios. And she was having, of course, difficulty in the scapular plane elevation because of adherences in the anterior inferior capsule. So this is her now 4 months post-op. Very good external rotation, still some difficulty in internal rotation, and still it was not easy to do elevation. See the scapulothoracical compensation. But with good physical therapy, this is her 8 months post-op, and with an outstanding result. This is my best result in the 20-25 reverses I have done in the worst case. My best result in the worst case. Okay, lovely. And then the pandemic came, and the patient came after 1 year. This is the last time we saw her, September 2020. She was coming to the city again, 1 year, 8 months post-op. Everything was doing fine in the X-rays, the AP, the axillary view here. And this is the last time we saw her. She was using a mask because of the pandemic. I like to say everybody gained weight with the pandemic, but she lost weight. And this is absolutely fantastic. I would never expect such a wonderful result. This is my best result in a reverse in 17 years in the worst case. So she is absolutely aware of all of the problems we may have in the future. And I conclude telling you that I am already preparing an article which will be published in October in Argentinian Orthopedic Association magazine about the challenging of doing a reverse in patients below 40 because of this case. The guys of Argentina, they got crazy with this case and they asked me to write this article. And this is her elevation. So I conclude saying this. A reverse restores the center of rotation. It tensions the deltoid, which would be quite good in such a young lady. And it allows good ROM, as we have been improving the technique, and is a good solution for many cases without any panacea. Take home message number 2. It was the classical indication as a shoulder and elbow guy I am is an irreparable tear in a pseudo-paralytical shoulder in a patient 70 plus. Okay, with few comorbidities, lucid, active, and collaborative. In 2008, we were discussing this, but the limits of science have evolved in the last 12 years. So the indications without any heroism and any panacea, they are increasing. Proximal humerus in fractures in elders, we know that's too much, but in very complex sequelae of the shoulder, it can be done regardless all of the problems in the future. This patient, she told us to conclude, Doc, if you are giving me, as you are telling, 10 to 12 years of a painless and good clinical scenario, and my life was being destroyed by that, I will thank you too much, and in 10, maybe 15 years, then we will see what happens. And I worry about that, but I am very proud of my surgery and my decision making. So I just want to say thank you to